I'm Sue Bornstein. I'm the Executive Director of the Texas Medical Home Initiative and co-lead of the Texas Primary Care Consortium. The Texas Primary Care Consortium is the only statewide collaborative with a mission to advance high-quality primary care for all Texans. It's co-led by the Texas Health Institute and the Texas Medical Home Initiative. The purpose of Primary Care Matters is to take a deep dive into topics that impact the provision of high-quality primary care in Texas and beyond. In our first installment, we discussed how primary care is the foundation of a robust healthcare system, and we explored some of the challenges as well as the opportunities to strengthen this vital component of the healthcare system. So in today's discussion, we'll examine several different primary care practice models and what can be learned from them. We'll also explore value-based payment models in primary care, the promise, and also some of the barriers to implementing value-based payment. Today, we are honored to have Dr. Sarah Candler as our guest. Dr. Candler is an internal medicine physician who's worked in a number of diverse practice settings. She has expertise in payment models and holds a master's degree in public health, which we do think gives her a unique perspective on healthcare systems. Dr. Candler has held numerous leadership positions in organized medicine, and in 2021 was recognized with the American College of Physicians Walter McDonald Award for Early Career Physicians. Sarah, please tell us a little bit about yourself and how you became interested in primary care as a career.
Thanks so much for having me, Sue. I came to medicine as a non-traditional student whose only science in college was geology. So, as a recovering humanities major, I always knew I wanted to practice relationship-based medicine. So, midway through medical school, I realized that internal medicine with a focus in primary care was the right fit for a big feeling nerd like me. I get to solve clinical mysteries and optimize chronic conditions. I follow my patients through varying stages of their diseases. And I also knew pretty early on in medical school that I wanted to practice more than just medicine. And I have very intentionally sought out these opportunities to learn through experience what is and isn't working in our current delivery systems in primary care. So I've been actively investigating the different components of our system in practice and in sort of the policy and organized medicine side, things like payment models and delivery models and training programs, patients and team-based factors, asking myself, not what do we need to work on? Because the answer, of course, is all of it. But where do we start?
Wonderful. So just to dive in here, the late pediatrician and health services researcher, Dr. Barbara Starfield, wrote about the four pillars of high quality primary care and named them the four C's. First, contact, continuous, comprehensive, and coordinated. And it's especially important to emphasize the first C, first contact. And that is really defined as the ease with which someone can obtain the needed care from a practitioner of choice within a time frame appropriate to the urgency of the problem. But the other C's, continuity, comprehensiveness, and care coordination, really cannot exist without getting the patient to the appropriate point of care. So the first C. Now, I do think that Dr. Starfield's work has really stood the test of time, and we're indebted to her. I also think it's worth noting that other researchers subsequently have added other C's, if you will, including Sarah, our mutual friend and colleague, Dr. Tracy Henry. And Dr. Henry and her colleagues suggested adding a convenience, cultural humility, structural competency, community support, and collaboration to the four C's. And they note that the original four C's may not be inclusive of the needs of under-resourced communities. And I certainly think we always want to think about health equity and how we can achieve that. So with Dr. Starfield's four pillars in mind, can you please reflect on what you've seen in various primary care settings, really compared and contrasted with Dr. Starfield's vision?
Oh, excuse me. Yes. Sorry about that. Thank you. Dr. Starfield and Dr. Henry both, I think, address some very important issues in primary care, and different settings are able to address some of those optimizations of primary care differently. Um, I would say in order to understand how they compare and contrast, we have to understand what that definition of primary care actually is, and then figure out how to make it high quality. I sometimes don't think even other physicians grasp the complexity of even the most basic day of primary care. So rather than running through all nine of the C's, I'm going to interpret them a little bit before applying them to day-to-day practice of primary care. So, according to Dr. Starfield and Henry, primary care is a relationship. That first contact is about a relationship. It's your first date. Can I even get to the person that is gonna be the one for me? Um, Convenience is the other piece of it, like you mentioned. That's a relationship defining quality. And then the thing that I really appreciate Dr. Henry for adding is this concept of equitable relationships, accounting for the cultural humility and the structural competency. Not every primary care setting is developed and structured in a way, reimbursed in a way that allows us to do the right thing so that everyone has the same chance to attain that same level of health. That's equity to me. It's the same chance. So the relationship is continuous and comprehensive. So it's a deep and sustained across time relationship, and it's interconnected. So the other C's that go in there, this coordination, the community support, the collaboration, we recognize that there's interconnectedness in that relationship. So as you mentioned, I've practiced in a number of different primary care settings, each of which facilitate this interconnected, equitable, deep, sustained relationship in varying ways, some better than others. So the spoiler here is that as a clinical practice, the relationship is more successful in a large network that makes it easy to communicate with patients or specialists or data. This would be like the VA or other large academic centers that I've practiced in. The day-to-day delivery model that facilitated the relationship best was value-based care under optimal settings. And that's an important caveat. This includes a single payer, single provider model like the VA, as well as a full panel, full risk value-based care of Medicare and Medicare Advantage, not this hybrid situation that I'm currently in right now, which is actually much more akin to the average primary care physician's experience. This average experience is really tough to attain Starfield and Henry's high quality primary care. I'll tell you a little bit why. So for background and training, I had a primary care panels in an FQHC, a VA, and an academic safety net. As an attending, I taught in a multidisciplinary academic VA clinic and then helped open a new market of private equity-backed primary care clinics for high-risk older adults on Medicare. And now I'm one of two physicians in a private practice whose payer mix is about 20% Medicare, 30% Medicaid, 40% commercial, and 10-ish percent of like uninsured or self-pay patients. So my current practice is mostly a fee-for-service payment model that's moving into some accountable care relationships with a few of our payers. So of all of my experiences, it most closely matches this everyday experience. I think I have a leg up on other physicians because I've seen what effective value-based care and team-based care can look like. And I think that those two things are components that are really, truly critical to attaining this high-quality primary care that Starfield and Henry have tried to attain. Um, we all know that it looks different in practice than it does on paper. So maybe the better way to explain it is to tell you more about some patients, right? Like an average day. What does it look like? So here's an average day. It's based on truly a day that I had. So first I call the patient of a family who passed away, the family of a patient who passed away. I have to express my condolences and ensure them that they have support and questions are answered. That's a relationship, right? Someone I had a relationship with passed away. And so I call them. Then I diagnose a communicable disease, notify the patient, notify the health department, counsel the patient on quarantine, limiting exposures to other people, and confirm the diagnosis, plan the treatment, all that stuff. Then I order a biopsy for a patient whose physical exam, the exam showed an abnormality. They weren't symptomatic, but I did an exam because it's a primary care visit. And I ordered some imaging, and the imaging confirmed that my exam was concerning, and there was a concerning thing that needed a biopsy. So I tried to call the patient, and they didn't answer. So I sent a message to the patient, and then a note to my staff to follow up and make sure the patient got the message. and the biopsy. And then I start getting paid because none of that is stuff I got reimbursed for. Because in a traditional fee-for-service model, none of what I just did is billable. It's all prompted by messages or results that I receive in the chart asynchronously from a visit, right? Sometimes asynchronous means days later, like a lab result, or weeks later, like an imaging result, or months later, like a patient who declined and ended up in a hospital and a nursing home and hospice. And the relationship exists over time. To get that high quality primary care, you have to be committed to the relationship that exists over time. Your job doesn't end when the patient walks out the door. The job continues because the relationship continues. So if you think about a practice model that facilitates these kinds of relationships, you must recognize its success depends on payment models that incorporate asynchronous care into reimbursement. Alternatively, you rely on the willingness of physicians to do the work essentially for free. And all of our friends who are experts in wellness and burnout can tell you how that's been going with us so far. Spoiler, not great, not great. So even before I start seeing patients, I acknowledge my primary care setting currently does not incentivize this high quality primary care according to Starfield and Henry. It's continuous and comprehensive. Um, I have so many other experiences in the same day that touch on so many of other of those C's. Do you want to hear a little bit more about some of them? Okay, great. So I look at my schedule. I see two patients that are listed for the same concern. Sinuses. I've never met either of them because some of my visits are held for urgent needs, and these are patients of my colleagues. So the first patient reassuringly probably has allergies. She needs over-the-counter stuff. The other has an abnormal lung exam, and I'm worried that it's pneumonia, and I'm worried that it's triggering a COPD exacerbation. So the distinction between the two, quote, sinus visits is a hint that the system needs to achieve these goals of the first contact, the convenience, the relationship that isn't just convenient for the patient, but you have to recognize that you can't exchange convenience for correct medical care. So some people would say, oh, patients who have a sinus problem should just have a video visit. Couldn't they just have a televisit? Couldn't they just do that? Well, maybe, but it's really hard to tell the difference between allergies and pneumonia in a video visit. Um, so the caution with things like convenience that can get us into trouble is recognizing that sometimes the most convenient thing and best way to be available to our patients, sensitive to their needs, is folks with a day job or difficulty getting transportation, is that we have to temper them with the efficacy and efficiency of the medical care that's needed. So you can't exchange the factors for each other. You can't toss out the comprehensiveness for convenience. So that's the other piece I'll say about these 4 to 9 C's is that you have to take them all in the context of the patient who's in front of you and the practice that you're in. And the other piece that I think is not a secret, but the depths of which can become mysterious, is this idea of the sort of interconnectedness of the primary care relationship that Starfield and Henry aspire to. The fact that you have these community connections outside of the care. So what if I told you that the patient with the possible low bar pneumonia had a question about the X-ray that I wanted to get to diagnose the actual pneumonia? Questions like, how much will it cost? Where should I go to get it? Do I need to call my insurance first? Why are they so worried? Well, because they were just diagnosed with cancer in another body part, and the surgeon ordered an MRI to plan the excision, but the insurance denied the order because they wanted it done in a freestanding radiology center, not the hospital affiliated one. Because, as you know, there are often facilities fees that make imaging tests more expensive in one place compared to another. It's the same test, it's just in a different place. And yes, I said to this patient, even if the two places are owned and operated by the same health system, and no, I said to this patient, I cannot explain why. When these two imaging centers who share an owner and a name, but not physical location, they are not able to simply transfer your information and appointment from one to the other, and why instead you, the one with the cancer, have to call and manually cancel one and reschedule the other. And obviously, these questions are not on my board exams, and you better believe they come up more often than a pheochromocytoma does. So don't get me wrong. I am not advocating for replacing rare diseases with insurance literacy on training and certification exams. But if we don't replace the current insurance system with something less confusing, we're doing a disservice to our new docs by not at least warning them that these questions are coming, and obviously a disservice to our patients who suffer the most. So, this interconnectedness of the primary care relationship requires things like EMR interoperability and price transparency and elimination of unnecessary costs like facilities fees, or at least making sure that those fees are not passed along to the patients. And the other thing I'll touch on there before moving on to the bigger picture is how we prepare for these challenges and overcome the barriers. And that's cultural humility. How do we make sure that the structure and the practice of primary care are equitable? How do we make sure everyone has that same chance to reach the same level of health? Same day in clinic, I celebrated with someone whose diabetes was poorly controlled and could finally start treatment for it. They couldn't tolerate the meds before because they'd been on long-term therapy for cancer and were really nauseated. So they were only taking the most critical stuff for malignancy. They weren't comfortable with insulin, so we'd just been waiting the next couple of months to finish this process. During a workup for the nausea, I also diagnosed severe untreated H. pylori. So they finished the cancer treatment. We treated the H. pylori, and today was the day we found out that we had cured the nausea. So at this appointment, we were finally able to start treating the diabetes, and the patient was thrilled. Big wins. So what's the cultural humility here? Well, part of the relationship is recognizing we can't do everything on our own schedule, as much as we'd like to treat everything at once. And insurance totally wants us to treat everything at once, right? What are you doing about this patient whose A1C is in the double digits? Well, I'm curing their cancer first, and then we'll talk about their diabetes. And what I didn't mention was that this person doesn't speak a lick of English, doesn't have technology to effectively use video visits. So all of our workup, our counseling, our treatment was completed in our office using a video translator through a service that we pay for by the minute. Do I want to use patient-centered communication? Absolutely. Is it critical to high-quality primary care that it addresses all 9 of the C's? Absolutely. Do I get reimbursed for doing it the right way per minute? Nope. Nope. Sure don't. So hopefully, I guess it's clear now that it's not just the practice setting that has affected my ability to achieve this high quality primary care, but it's the payment model that
Sure.
facilitates those settings. And it acknowledges the patient complexity, medical and non-medical, reimburses for overall care value rather than specific tasks. And that is really critical to this primary care setting. And when you do that, you also have to acknowledge that there's one other component, which is renewed trust in primary care. As a system, we do not value primary care itself.
Right.
Um, yeah.
Uh,
I have one more patient that I'll tell you about in a
Sure.
minute that'll tell you about that talks about that trust piece.
Okay. Well, I think you've done an excellent job really putting the theory into practice and explaining what this looks like in your day-to-day work, and very, very informative. And so we've talked a couple of times about fee for service, and it is not any kind of a secret that the prevailing fee for service payment model is not conducive to high quality primary patient-centered primary care. And why? Well, it's very simple. And you've really described this, I think, very eloquently. Fee for service rewards discrete services, widgets, if you will, rather than what you just described, Sarah, complex, comprehensive, and coordinated care that's difficult to capture with individual visit codes. And I think that is really the crux of what you are saying. We're both saying we do need a fundamental change. But so, what is the remedy for this? Well, we've talked about value-based care, value-based payment. It's interesting. I think if you mention this term to 10 different people, you're going to have 10 different interpretations. And these are people that are practicing medicine. And so it's a broad term and it encompasses a number of different models, which you've mentioned a couple of them. And the goal is to reward physician practices for the work that they do, and hospitals also for delivering high quality care and achieving positive health outcomes. And that's the part that really fee for service has never been associated with. And so I think that's a big part of this. But so what are they? Well, there's a lot of them, and you've mentioned a couple. They're accountable care organizations. They're bundled payments. They're the patient-centered medical home, which is where we all started with this many years ago. Capitation, which still scares some people. I think understandably, pay for performance. But the other thing we know is that the move to value-based payment has been slow. It's really been very slow. I think the Commonwealth Fund did a study like in 2023 that showed only 46% of payments to primary care practices were value based. And so, right. And even though the federal government has definitely pushing for Medicare in particular and Medicaid to come by 2030, I think they want them to achieve 100% value based payment. And even in Texas, in the managed care organizations, they are pushing to do this, and it's a challenge. It's a challenge for them. But it really the lagging part is in commercial payers, right? And that's the challenge. So if I was explaining this system to someone recently and said, all right, so you want to give, as a clinician, you want to give the same standard of care to all your patients, right? You do. You've said that, and that's right. That's what we do. But now 40% of them have some commercial payer, and 20% of them have Medicare, and 10% of them have Medicaid, and 10 or whatever have or do not have insurance, or so private pay. Yet you want to transform your practice in a way that you can give equitable, equal care access to all those people. I think therein lies a big part of the challenge. And so I do kind of have to put a plug in here for the Texas Primary Care Consortium and say that we were really one of the primary supporters of House Bill 2254, which did pass in the most recent legislature. And this allows for PPOs and EPOs to enter into value-based payment models. And it's surprisingly something that was prohibited until now. And there's historical reasons for that. And there are ample guardrails in the bill, and practices do not have to do this, and they will not be penalized by insurers if they don't do it. But it's a leg up, I think, for a lot of practices. Now, you mentioned the uptake, or we've talked about that, and I think that the data does show, the evidence is clear that value-based payment models have a higher uptake in urban and suburban areas, and as to your point, in practices that have 5 or more practitioners. And so you've had a lot of experience, more than most, with value-based payment models. So, and we've already alluded to some of this, but we'd love to hear from you what you think of the potential benefits and some of the maybe additional challenges that we haven't already talked about that are not only involved in implementing them, but operating them on a day-to-day basis.
Great points. First of all, congratulations and thank you for working so hard to make these alternative payment models accessible in Texas. May such benefits go across the country. I think you are exactly right that these models, I think are the way forward. I think it's how we achieve that equitable care for all of our patients and our physicians and our teams who need to work in these settings. I think it's the right way forward. And I say that with the experience of having done it in lots of different ways. And I think and I know, because as you say, data show this, they are not successful unless they are optimally implemented. And optimal settings mean that actually you do this for all of your patients. So in many practices, including my current one, where we have a couple of relationships with payers that are moving towards accountable care, meaning that we would get paid for performance. We'll get paid for, quote, doing the right thing and taking care of our patients in the right way. But we're only doing that with a couple of our patients. And rather than try to only identify which patients need to get their colonoscopy on time so that we can, quote, get paid for doing the right thing, shockingly, we're already trying to do that for all of our patients. So we're trying to build a system that identifies all of the patients who are due for their colonoscopies or all of the patients whose blood pressures are not controlled. Now, I've worked in two very functional settings that do these kinds of things. And I'll tell you one of the things that made both the VA and that sort of private equity Medicare facing plan setting work is that their electronic medical records, were designed to assist with population health. So some of what gives us that success in the uptake is the technology. Because I personally, because I know what it looks like, have now gone into my current EMR and tried to build the reports myself. Because the accountable care organizations will only pull them for the patients that are participating in their plans. But what is gonna make it more effective and honestly more efficient? Efficiency is because my team will know that all of our patients are treated the same way. All of our patients will have this checklist of things that they're due for and will have the same protocols for getting blood pressure under control and rechecking A1Cs in a reasonable manner and making folks have had their diabetic eye exams. It is very difficult to train any teams to do different things for different people. Just from an efficiency perspective, that's just silly. This is why back when Henry Ford was building cars, they started having assembly lines because you can do something faster when everyone has an expertise in a certain space. And the technology is part of that expertise. So the electronic medical record can certainly help us in part of it, as part of building that optimal setting. The team training is another one. I mean, some physicians are not even trained to work in a team, right? It's not part of their education. I had the benefit of teaching in a space at the VA that was an interdisciplinary training program. So we taught the physicians and the nurses and the NPs and the pharmacists and the social workers all in one room. We taught them in one room. When we had primary care clinic, all of those humans and trainees and their attendings sat in one room together so that we could model what it looks like to work as a team. Because none of this is doable just by a physician. I mean, part of the concern that people have about value-based payment systems is that it's too much work. And it is. I mean, if I by myself had to do all of those things by myself, it's absolutely too much work. I also argue that some of it is too much work in general when we have technology that could probably do some of it for us. So we got to do that too. But in the meantime, we really do ourselves, again, a disservice when we don't recognize that some of the work makes the overall goals happen more quickly. So I'll give one example of a criticism of these value-based models that I think can help us get somewhere more effectively and efficiently. That is this idea of the managed care. So one of the examples you gave, these sort of accountable care or managed care organizations, but are given that name because the insurance plan tells the physician what they can do. And goodness gracious, nobody likes that. The best news is that when done well, the algorithms are usually based in evidence. And I am not trying to make excuses for any of my insurance colleagues, but I will say that, if you start to understand where they're coming from, you could anticipate if the algorithm is evidence-based, and not all of them are, as we know very well. So managed care organizations are telling physicians what they can and can't do based on algorithms and step theories, step therapies. Physicians hate this. But what if I told you that this could be an opportunity to teach primary care teams how to practice at the top of their training? So, for example, when I worked at the VA, I had step therapy requirements and algorithms for medications, for imaging, and even for referrals. So, if I wanted to refer someone to a urologist because they had hematuria, they had blood in their urine, and I want to know if they have bladder cancer, I couldn't send the referral until I had documented that I had checked the urine twice and I had gotten a CT urogram to rule out the relatively benign stuff of a non-obstructing kidney stone, and therefore made sure that I was sending the specialist something that truly required specialty care. And now, as a result, in the community that I work in, not at the VA, I have a hard time getting my patients in to see urologists. Sometimes because we don't have enough in the neighborhood, sometimes because insurance networks are narrow, sometimes because my patient cannot afford another copay this month. And I know that I know that there are places that think it's still okay for me to do the rest of that workup. And I can get someone in faster because I can then call them myself and say, I did a urogram, I did a repeat UA. I'm worried this is bladder cancer. They need a cystoscopy, and that. They will get that referral. So some of that managed piece, I think, has benefits. Um, the administrative work, which is the other big complaint, is certainly something that I think technology can and should help us with. And that includes the billing piece of it. That includes population health. I do not think we should be relying too hard on other humans to be doing that work right now.
Wow. Okay. There's a lot to chew on with that. And I all we all appreciate your expertise and your insights into really what it looks like on the ground and what some of the challenges are. And so the other thing, and I neglected to mention this, although this is not really the focus of this discussion today, but it really has to be said, and that is that for all the work that you do every day and all your colleagues, our colleagues across the globe and across the country in particular, primary care is paid basically 5 cents for every dollar that is spent in the U.S. healthcare system, which we know, I saw yesterday, is now going to be in the multiple trillions of dollars. It's very interesting. We recently heard some feedback from focus groups that had been done up in New York about messaging about primary care and how do we appropriately message about primary care to get our message across. And one of the most fascinating parts was they asked people, these are regular people that they recruited to be in these focus groups. So how much money do you think, again, what percentage of the dollar that's spent in healthcare is spent on primary care? And it might not surprise you that most people thought it was at least 50%, if not more. Yeah. And so when in fact it's closer to five, it might be six in some places, it might be seven, but that's rare. And so to me, that's a great opportunity. Again, I think it is not always the most beneficial for us to focus on the money, quote unquote. I think rather it is appropriate for you to describe, as you have done so well, what your day is like and the things that you do as a primary care physician to enhance those relationships and to provide the kind of care that you that you are so well trained to do. And I've thinking, making a couple of notes while you were talking, and it strikes me, Sarah, that part of what you're saying, part of the message is high touch has to stay, right? High touch medicine has to stay. And I think that the tale of the two sinus infections is a great example of that. High touch has to stay. And it can be facilitated by high tech. And I think you are okay with that, right? And I think the fact that this was an important statement that you made, that telehealth, telemedicine cannot replace the human touch. It simply cannot. Can it augment it? Yes, it can. but I don't think it will ever replace it. So it seems to me that what we really want, and again, harkening back to Starfield and Henry, is how do we get back there, right? How do we get back to the place that we know we want to be? And I think that you have very, very expertly elucidated some of the ways that we can get there. So I guess just I would be curious, and as the eternal optimist that I am, uh, do you think, are you hopeful that primary care in this country can achieve its potential? Do you think that that can really be reality and reduce healthcare spending? So achieve, improve population health and reduce healthcare spending. It's a big order.
It's a
Do you think
really
it's
tall
possible?
order.
Yeah.
Yeah. Um, First, I'll say you are absolutely right in interpreting my assessment here. I think that in order to achieve high quality primary care in this country, we need to increase utilization of technology and other resources to facilitate science and evidence-based care so that the physicians can continue the art of medicine. We have always said that this is both an art and a science. The art of it is a thing that's very, very hard to replicate through AI and other technologies. It's very difficult, though possible, depending on what the concerns are, to practice even in a virtual way because of the importance of that human relationship and in many cases, the human touch that goes with it. We must leverage technology for the science so that we can unlock the power of the art. And I do think that we need to respect primary care a little bit more, both in funding and culturally. I'll go back to that same day with one last patient. It's in the win bucket for that first contact. I had a hospital discharge follow-up. I had sent them to the ER via ambulance for chest pain, and as they were wheeled out, EMS had said to each other, and then I found out later to the patient again, huh, 2 months of chest pain, so I don't know what they're going to do for you in the ER. True story. And of course, I had sent him because 2 months of chest pain had been increasing in intensity and frequency until that morning when it lasted longer than usual, and in fact had not yet fully gone away. So I spent actually a good part of my conversation with that patient before EMS arrived explaining why it was important to go to the ER, explaining that I can't rule out a heart attack in my office. And I'm worried it could be that. Is it for sure going to be that? I don't know. But it's worrisome enough. And I am a physician. I am trained for this. And I think you need to go to the ER. The follow up I had was 10 days after my first visit with him because he had been admitted and had multiple stents placed to the LAD, the Widowmaker. Both the diagnostic visit and the follow-up, by the way, were scheduled for 15 minutes. So obviously, those only took 15 minutes, both of them, obviously. So, and those are truly all patients I saw in one day, literally one day. And I saw 18 patients that day. Those were six of them. We didn't even talk about patients with dementia who showed up without their family or the medical mysteries that I love thinking about because I'm internal medicine. And I feel comfortable sharing all of the stories because none of them is unique. I have had similar, if not identical, patients to these and days filled with them multiple times in my near decade of practicing primary care. So we have to recognize that the practice settings are driven by the payment models. We have to train physicians and give them the resources and the time to care for people with the complex needs. Do I think that we can achieve high quality primary care and make people healthier as a whole in this country? Absolutely. We are known for having excellent medicine. Do I think we can do it in an equitable way so everybody has a chance to get there? Uh, we got to be willing. We got to be willing to build a system in an equitable way that isn't fee for service, that is understanding that sometimes the quote cost and the energy and the quote work is not something that I can predict in a reliable way enough that it's reflected in a number. To your second question, I do think on a whole, yes, we can decrease healthcare spending, but not by decreasing primary care spending. And you said that earlier. It is well known that investments in primary care, not so it goes into my pocket as a primary care physician, but total reimbursement to the practice, to utilize technology, to hire staff, to build a team, to have those frequent touch points. Those investments in primary care can decrease overall cost of care. Yes, it's possible if we're willing to try.
Wow. So this has been just such an informative and inspirational visit. And I can't help being reminded of a very famous statement that I know you have heard many times, but I think it's very appropriate here. And that was what Francis Peabody said well over 100 and some years ago, that the secret of caring for the patient is caring for the patient. And at the end of the day, that is the secret sauce of primary care. And I think you've done a fantastic job explaining what that looks like and how we can get there. And Sarah, we all appreciate you being here today, and thank you so much for joining us.
Thanks for having me.